and welcome to another podcast. Today we're going to talk about envenomation. Now, envenomation seems to be a favourite topic for lots of people, particularly during first aid classes or when you're talking to non-clinicians. It has a lot of popularity and there's a lot of wives' tale and a lot of misdemeanors associated with envenomation. So today the focus is to talk about venom, and in particular venom within Australia, and really break down the epidemiology and then look at the real clinical features and management that we should consider in the environments that we work in. It should come as no surprise to most people that envenomation as a topic is an enormous one, and we could break this down into a series of each animals, each region, each type of venom, and really go to town on a whole bunch of different lessons. So what I've done instead is I've created this lesson that will go through the big envenomations and the ones that result in some sort of medical emergency. But then I've also written a study guide that will be on Adele that goes through a lot of the other creatures and a lot of other considerations around marine life and land life as well. So I encourage you to have a look at that. But to start off on this particular lesson, we'll just have a quick talk about venom. And venom itself is a huge umbrella term and is extremely complex in nature. So trying to group venom in a class is quite difficult. So what I talk about now in regards to an introduction to venom, we'll just go through generalized pathophysiology, if you will, and processes that venom proteins generally go through. So whenever you get venom, and just to be clear, venom basically means if something bites you and injects a substance or proteins within you, they are envenomating you. So that's what venom is. But if you ingest something or absorb something, then that's poison. Okay, so venom comes with an element of penetration beforehand. And venoms contain proteins, and these proteins react with a huge amount of body systems and enzymes. Okay, so we have enzymatic venom molecules, and what they do is they basically cross over all lipid membranes and they interact with pretty much every cell within the immune system. Okay, so we're talking our phagocytes, mast cells, complement proteins, cytokines, leukotrienes, all forms of leukocytes. So both in innate and adaptive immunity, these proteins have some sort of an influence with it. Now, the main thing that happens when venom comes into our system is we get a profound inflammatory response. So it brings on that localized inflammatory response that in turn spreads to a systemic response. So it's almost like the venom occurs a SIRS criteria, so a systemic inflammatory response syndrome within the body. And that can be one of the side effects that can obviously lead to hypertension, cardiac arrest, hypoxia, seizures, all the things associated with a profound distributive shock or a profound inflammatory response. Now, on top of that, venom can also interfere with the synapses and cause paralysis. Now, it can be paralysis of certain muscles, whether it's cranial nerves, so you'll get facial or eye drooping, or it can be spinal nerves, where you'll actually get respiratory paralysis as well. And that can be the case in the blue-ringed octopus, for example, or the cone shell. Not all the time, but it can happen. Other types of venoms are very good at messing with coagulation. So it interferes with cytokines, prostaglandin, and COX enzymes in order to interfere with the clotting cascade. So like a non-steroidal anti-inflammatory, but on steroids, if you exclude the pun, it creates a huge coagulopathy problem, which in Australia mostly causes the inability to clot. There are some venoms overseas that actually encourage clotting, but we don't seem to see many of those in Australia itself. If we change the class of protein that we're looking at from types of venom and we move to the ones that interfere with things that aren't enzyme related, then we also have the ones that interfere with cellular replication, and they can actually cause apoptosis, or in most cases will actually cause necrosis of the actual area itself. So as you can see, venom as an umbrella term is very complex, okay? And I haven't really given it justice, but I don't really want to delve into the different pathways of venom because they themselves are a 40-minute lesson alone. The good news is we have experts, and we have a wonderful center of excellence called the Poison Information Center. So 13 11 26 is a 24-hour call line that you can call anytime for all types of poisons and envenomation and get advice. They're there for clinicians, they're there for novices, and they can provide sound advice to you on the region you're in, the symptoms the patient is showing, and the best management for that individual. Okay, so if you don't remember anything from this lesson, please remember the Poison Information Center and have it saved in your phone at all times, especially when acting in a remote environment. From venom, we'll have a look at some of our creatures, and we'll look at the epidemiology of a lot of these cases. And we'll start with one of the most famous in Australia. Australia is known for its snakes, but luckily for everyone in Australia and all our tourists, it's not very common. Okay, so a snake bite itself is not very common. We're talking about 80 calls a year in Australia on average since 2007 until I got the data from 2022. So between 2007 and 2022, there were 80 calls on average per year. Now, to give that a percentage of all the calls that were done, emergency calls that were made within Australia, we're talking about a 0.0001% call rate for snake bites. And of those 80 calls or non-calls, there's on average 2 deaths per year in Australia from snake bites. And most of those are associated with snake handlers or people that have been messing around with snakes. Now, if you want to talk about toxicology a little bit further, the brown snake itself is the most deadly, not necessarily the most toxic, but the most deadly, and it's mostly due to cardiotoxic and coagulopathy effects. So it actually will cause arrhythmias and cardiac arrest, and it will cause clotting problems. So the patient will actually bleed out. Now, because of effective management in first aid and a few other variables like snakes will often dry bite in order to save the venom, or they just use the venom on a smaller creature. So when they actually bite you, they don't actually inject the venom, they just want to scare you to make you move away. So that is most of the time, to the extent that of the 80 people that are called, they all go to hospital, they all get treated the same way, but between 40 and 50% of them don't actually receive any antivenom at all. So the effectiveness of the first aid treatment is enough, and they won't actually ever need the antivenom. Now, to give the antivenom is actually quite a decent clinical choice, okay? And you only ever give it on advice. Definitely for us, we only ever give it on advice, and most of the time we don't even carry antivenom because it's quite hard to store, very expensive, and has a pretty crap shelf life, okay? So most of the time we won't have antivenom on us, and even facilities within our region won't have antivenom on them. If you go to a facility with antivenom, it's always a judgment call of whether or not the person should get it, and it's often based on the symptoms that we'll look at. Now, a very large study that was looking at the use, misconception, generalized dose and protocols of antivenom itself found that on average, of the 1,200 odd patients who received antivenom, 12% of them had some sort of side effect. Okay, so we're talking a very high side effect rate, and the side effect ranges from allergic reaction all the way through to anaphylaxis. Okay, so it's quite a dangerous medication, especially if you're giving more than one vial. So always keep that into account, and realize that even if you're in a facility with antivenom, a good chunk of the time patients won't actually need it, and to give it comes with inherent clinical risk. Moving away from snakes and moving into spiders. Spiders are probably the most unjustly hated creatures on the planet. Okay, they seem to invoke the most amount of fear and phobias with really not a lot of data to support it. I mean, sure, they look a little bit creepy. They crawl across you, so many legs touching you at once. I mean, I sort of get the discomfort, but at the same time, they're not very deadly. Okay, spiders aren't very deadly creatures compared to others. So bees, for example, beautiful, wonderful bees that we could never live without, are actually more deadly than all the spiders combined. Okay, so that's something to take into account. Now, please don't run out and be scared of bees and start killing them en masse, okay, because we absolutely need to protect them. But it's just a way of indicating how probable it is to, one, get bitten, and if you get bitten, to actually have a severe effect from spider bites. So there was a case, and it was relatively recently, and it's quite a tragic case actually. There was a young man in 2006 that was bitten by a redback, and that redback bite caused an infection. So he went to hospital, he was treated with the antivenin, he was treated with antibiotics, and he was discharged from hospital, but then within the space of a week, he actually passed away. Okay, now that has in some papers been attributed to death from a spider bite, where in other papers don't. Now, I'm not going to go into much more detail or discussing it any further out of respect of the family, because it was quite a tragic event. But before that, the last confirmed spider death was in 1981, and that was when the funnel web spider antivenom was actually invented. Okay, so since the funnel web spider bite, the antivenom was invented, there has been no death from funnel web spiders, and minus the one in 2016 that we just spoke about, there's been no death or quantified death from redbacks since the 1950s, when that antivenom was invented. Okay, so that's pretty good odds. But when we talk about the big spiders that everyone knows, because there's around 10,000 species of spiders within Australia, okay, not to scare anybody, and realistically there's only a few classes that meet the criteria for most deadliest. And surprisingly, huntsmans make the list. Okay, now we all know huntsmans aren't venomous at all. Okay, they're large enough to track down their prey and crush them, basically. But they like to hide in cars. Because they like to hide in cars, people get scared and crash their cars, so they get put on a list as death by spider. Okay, but that's a bit of a stretch if you ask me. Now we all know the funnel web spider, and the funnel web spider from Sydney is the class that gets the most attention. Now it's not only found in Sydney, it does spread up the east coast from Sydney, beyond Brisbane, and there are 6 subspecies of other funnel web spiders that also have a very, very similar venom, as too does mouse spiders. Okay, so in reality, they all have similar characteristics of being a larger, black, like fat black spider, which is generally what we denote as a funnel web, in inverted commas, and treat it accordingly. Now, of these funnel web classes, there's about 30 bites per year of this whole class of funnel web spiders. And as I mentioned, no deaths since 1981. Now, redbacks, on the other hand, because of where they love to hide and where they love to occupy, they love houses, they love dark areas, they love tires, they love wood heaps, they love old storage farming equipment. Okay, so people are more likely to get bitten by redbacks because they stick their hands in areas when they're cleaning things out or when they're collecting things for camping, whatever it is, they get bitten. So there is around 2,000 reports of redback spider bites, but of those 2,000 reports, only around 250 get antivenom. Okay, so they're bad enough symptoms, or children, elderly will actually receive antivenom. And as mentioned, there's no official deaths since 1950. Now, whitetails are horrendously misunderstood, and have a lot of wives' tales about them. One of those things is the venom is necrotic, so it's a necrotizing venom. So if you get bitten by a whitetail, you're going to have a necrotizing wound. Now, I agree that there seems to be a lot of anecdotal evidence supporting this. Now, whether or not it's just that necrotizing ulcers have been misdiagnosed as whitetail bites, I don't know. But what I do know is scientists have tested the whitetail's venom and it has no evidence of necrotizing features. Okay, that's all I'm going to say. Okay, don't cancel me just for reading out the numbers. All right, so that's interesting. And of all the other ones that we mentioned, so 9,980 odd spiders, they basically cause local irritation. Okay, that's if they bite you at all. Moving from the land and going to our favorite place, the ocean, the sea, there are a lot of creatures in the ocean that are very dangerous. When you think about it, ocean-based creatures sort of need to be venomous because everything in the ocean is very fast. There's a lot of current and food sources are few and far between. So they need to take opportunity in order to inject their venom in order to get the food that they're looking for. So marine stings are the most common. So stings from marine life are the most common things, but most of those are very, very minor. So stings mostly occur from jellyfish, and of all the jellyfish out there, it's mostly the blue bottle jellyfish, which causes localized pain and irritation. Okay. We can also get penetrating injuries from fish. Okay, lots of fish species that will actually have penetrating injuries. Stonefish is probably the most famous, but then we also have our urchins and our cone shells as well. And bites are actually quite rare, and we're looking at the blue ring octopus. Now, when we look at toxicology associated with marine life, the numbers of poisoning from marine life vastly outweighs the number of envenomation, and that comes from eating different types of fish. Now, on the same Adele page, I've also posted an article which is quite an interesting read that breaks down all of the different animals and treatments associated with those creatures, and reading the poison information is actually quite interesting to know. Okay, so feel free to have a look at that one. When we look at the bad ones and we look at stings, when we have the species known as the major box jellyfish, they are the most venomous animal in the world. Okay, they've been known as, yes, there's some debate left and right, but lots and lots of reports come back that says that that creature is the most venomous animal in the world. And there has been around 70 deaths in the past 30 years, and unfortunately most of those have been children. Okay, so they are, compared to the other ones that we just spoke about, they are quite deadly. Okay, so only just deadlier than all the snakes in Australia. Now, when we talk about irukandji, a lot of people seem to get confused that irukandji is a special species of jellyfish that lives in the ocean. But irukandji itself refers to the syndrome that occurs from a class and a number of species of jellyfish. Okay, so there's a few species that have been quantified, but there's lots of anecdotal evidence of other species that cause irukandji syndrome. Okay, and since irukandji syndrome has been invented or discovered or quantified, there has been one reported death. And lastly, if we look at our cutest little octopus, the blue ring octopus, its little blue tentacles, it likes to live in rock pools. Okay, very cruel for young children, if you ask me, because they're adorable. They obviously are extremely venomous. Okay, but most of the time it's caused by people touching them. And when people touch them, they get a bite. Now, depending on how good this bite is, will determine how much venom actually goes into someone. So most of the time, believe it or not, even if you're bitten by a blue ring octopus, most of the bites are actually quite minor. Okay, and there's been no reported deaths that I could find from blue ring octopus itself. Okay, so let's not forget that of all the creatures in Australia, we also have the platypus barb. Okay, that is also quite venomous, but I personally have never heard nor read of anybody that has been envenomated by a platypus barb. Okay, so like a lot of these things, it is statistically quite rare, and most often it occurs when somebody interferes in an animal's environment or get caught in a situation where the animal gets scared and bites you. Okay, we need to remember that most of the animals that we're talking about do not want to envenomate us because we're not a viable food source, and they are purely biting us in defense to cause pain or to scare us, basically. Okay, that's the idea. Okay, but moving away from epidemiology, let's take a closer look at our clinical presentations and managements for some of these more deadly creatures. And we'll start with snakes, because snakes seems to be the easiest and it's one that a lot of people will talk about. Now, when we talk about a snake bite, it's one of those ones that even though we know the statistics and we know the probability of envenomation and we know the likelihood of needing anti-venom, etc., we still encourage every single clinician, every single person who works outdoors around snakes to always treat snakes with a high priority assessment and evacuation to a medical facility, regardless of the snake, within reason. If you're a snake handler and you're handling a python and you get bitten, okay, not envenomation, but you still have to look into things like tetanus and that sort of thing. But I digress. So sometimes there's associated paranoia around snake bites, and snake venom can take time to kick in before any symptoms are shown. Okay, so don't think if you rock up to someone 20 minutes later and they have no symptoms that they're not envenomated, and don't treat them accordingly. Okay, you still treat them and you still go through the motions that we'll talk about as far as management. But just know that some people can have no symptoms whatsoever and just subjective data of saying, I was bitten by a snake. Now, I will admit that I have evacuated somebody on the pretense of a snake bite, and it turned out to be a stick. As they're walking through the bush, a stick snapped, twisted around, hit their leg, and they thought it was a snake. There was a mark on the leg. I wasn't going to argue, treated it as a snake bite and evacuated them. Okay, no harm, no foul, and that's what's encouraged to do. Other things you can see is you can see a bite mark. It can be a nice little red patch of swelling with bite marks in between or scratches. Okay, you can legitimately see that, okay, but not all the time. As envenomation continues, you can look for other signs like altered level of consciousness, people collapsing. They can go into that emergent state that we spoke about of hypertension, cardiac arrest, and seizures. But before they get there, we can have generalized signs of abdominal pain, diarrhea even, sweating, and then we get the coagulopathy effects, bleeding gums, side of the eyes, all that sort of stuff can occur. In some types of snakes, you can get blurred vision, so it can interfere with the actual cranial nerves and the paralysis of the eyelids, that sort of thing. Okay, so have a look out for these general symptoms, but most of the time, just realize that if someone says that they've been bitten by a snake, that's your clinical indicator to treat it as a snake bite. If someone doesn't know they've been bitten by a snake, but they felt something, probably could have been, still treat it and then go through the motions of monitoring the person as you arrange for evacuation. Looking more deeply into management, snakes equal evacuation from our environment. Okay, don't hang around, get rid of them all the time because most snakes have the potential to be venomous. So play your cards, arrange for evacuation. Apply pressure with immobilization. Now, I've deliberately separated those two because both of those are equally as important as one another. So PIB or PIT or all these other things basically means that you do pressure bandages and you immobilize the person. Pressure bandages are very important to slow down lymphatic flow, but stopping muscle contraction of the body is also very important which is what immobilization means. So having the person not moving is more important than sticking a stick in between someone's leg to treat it like a fracture. Okay, we really just need to stop them moving. And whatever you need to do for your patient to stop doing that is how far you go at securing them and immobilizing them with bandages and things like that. So we either put it on or we check the job of our first aiders. Now, yes, we have recommendations of bandage over the site, then starting at the lower limb and working your whole way up. If you have enough bandages, cover the entire thing. If you don't, you're in a position where you're really stretched, then you should encourage pressure over larger muscle masses, second to obviously the bite site. Now from there, after we've done the first aid, and it's the first aid that really saves these people, okay, so don't give it lip service, it is very, very important. We go through our additional clinical and we get cannulas in. People can need fluids, they can need antivenin, okay, so we go through the motion of getting 2 cannulas in and we monitor the vitals, we monitor the cardiac, and we always investigate for signs of envenomation. So we check for bleeding gubs, we check the muscles of the eyes, droopy eyelids, eye movement, double vision, respiratory effects, okay, and we constantly monitor them as we wait for evacuation. If we have time and we're in the vicinity, we can do pathology, and looking in the urine for blood can be a good indicator of envenomation, and you can also take pathology, include full blood count, UNEs, creatine kinase, coag studies. You can do INR and D-dimer, okay, but just be aware if you're using an ISTAT, they seem to have a lot of false negatives, are very, very common with the D-dimer and the INR when you're using an ISTAT. Okay, so if it's part of the suite with the cartridge you're using, go nuts. But if it's a specific cartridge, then obviously just give it with a grain of salt, basically. Now, if you're in a position where you are treating this person and you're in a facility with antivenom, so you're going to hold on for them a long time, then you can move into intrafluid therapy, because these people are generally nil by now because of the associated nausea, vomiting, and paralysis. And it's a good idea to insert an indwelling catheter and start a fluid balance. Okay, sometimes with the breakdown of the tissue and the associated inflammation of the body, the kidneys can get clogged up. So maintaining a fluid balance can be a great way to indicate perfusion status and also whether or not kidney function is working. You can also periodically test that urine with a urinalysis for signs of blood or proteins in particular. Okay, moving away from our lovely snakes, we'll talk about a more complex profile, and that's spiders. Now, the reason spiders are quite difficult to initially manage is because we don't know what the spider is. And because of the associated anxiety and fear surrounding spiders, there are a lot of cases that a big black spider was seen when it was in fact a huntsman or a wolf spider or an orb spider or something mundane like that. Okay, so it does get very difficult to know what we should do in regards to clinical presentation of our spider bites. Now, generally speaking, the presentations can be extreme. So if you get bitten by a funnel web spider class, you can deal with massive cholinergic symptoms, okay, where you can have muscle twitching, you can have all your hair standing on end, severe sweating, vomiting, nausea, bradycardia even, drooling, a huge amount of saliva. All these things can kick in, which makes it very, very obvious. But that's quite a severe case of envenomation from a funnel web spider. And you sort of want to start the treatment before they get to that point. Okay, so it can be difficult. The recommendation is history of a painful bite by a black spider. Now, they often say it was a black spider with huge fangs. They say that's indicative of a funnel web. Now, don't get me wrong, people like to exaggerate. Remember when my daughter was 7, she told me that she saw a spider the size of her 3-year-old sister, and she was adamant Didn't matter how many times I tried to convince her that those sort of spiders don't exist, that was the case. And still is the case today that she's almost an adult. Okay, so people tend to be irrational when you're dealing with spiders. Best thing you can do is monitor for the symptoms. If you believe it could be a funnel web, treat it as a funnel web. We look for the other bad one, the bad class, that's a redback. Now these ones will generally be bitten in an area that redbacks like to hang out. In the event they're bitten by a redback, okay, and they sort of think it was a redback, whether it was confirmed or not, you can treat it as a spider bite and monitor the symptoms. Now the symptoms of a redback spider bite are quite unique. Okay, initially, it's not very painful. Okay, it's not very painful at all, and then as time passes, it can be close to 30 minutes. Then they start getting pain, and the pain is in the area, but then it becomes like a large regional type pain instead. You can actually get, unlike the funnel web where you'll get all over sweating, you can actually get localized swelling and localized hair standing on end, as opposed to the systemic effect of the funnel web spider bite. Okay, so these are some clues that you can look at when you're dealing with funnel web versus redback versus the other 9,900 spiders that could have potentially bitten you. Now, when we decide what to do for management, it can be difficult. Okay, it can be regionally based, can be based on our health support planning, and a lot of the time we need to decide whether or not we're going to use pressure immobilization technique or not. Now, obviously, it's the funnel web spiders that get the pressure immobilization bandage because their envenomation is quite profound. Okay, so that's why we use it for that. Okay, the venom is deadly, and if you use it for a redback, it generally increases the pain. Okay, so that can be an indicator, if you will. Okay, so funnel webs get pressure immobilization exactly the same as the snakes did. No difference at all. Now, if we're thinking that it could be even remotely a funnel web spider, then we arrange for evacuation. But we put the indwelling cannula in, okay, and we constantly monitor the vital signs. Okay, these people can be subject to severe envenomation. Okay, and the severe envenomation can be quite dangerous. Okay, obviously, because it's the cholinergic symptoms. Okay, so we need to monitor for those and really arrange for evacuation to a facility with antivenin. Now, if we're dealing with a redback spider bite or really any of the other spiders out there, then we tend to start the management with ice. And they can also get analgesia. And depending on the spider, like the redback in particular, at that around that 30-minute mark, 10 to 30-minute mark, they can need analgesia, and quite decent analgesia as well, to support the pain. You're encouraged to clean the wound of all spider bites and consider someone's tetanus. In regards to envenomation, it is all spiders that could remotely be funnel web based, so any cholinergic symptoms, any probability of funnel web gets evacuated immediately. All the other spiders, we basically play it by ear on the patient and the severity of the symptoms. Now, most people with a redback spider bite or any of the other spider bites won't actually get too many signs of systemic envenomation. It's usually localized envenomation, except for the very young, the very old, and the already sick. So if you already have a patient who's quite sick that subsequently gets bitten, okay, because don't forget, these spiders like to hang out in areas that humans like to play, then these people need to go to a facility with the antivenom. If you're ever in doubt of what sort of spider it is, play it by ear, monitor the person for a while, call the poison information hotline, call the doctor, have a conversation, constantly monitor these people, and prepare for evacuation if needed. Final class we'll look at, obviously, is our marine life, and we'll pick the two of the pseudo-deadly ones. Okay, so we'll start with our box jellyfish, that most venomous creature in the world. These creatures can cause cardiac arrest. Okay, they absolutely can cause cardiac arrest. People can be dragged out of the ocean in cardiac arrest. Okay, so make no mistake. They're not in cardiac arrest, they're often in severe pain, and they look like they've been lashed by a cat of nine tails. Okay, they have big whip marks across their body, legs, chest, wherever it is, and they have almost like a frosted pattern that looks like a ladder, basically. It's quite distinct. If you've seen it, you'll know it straight away. If you don't know what it looks like, look up pictures and you'll be like, okay, I'm not forgetting that. On top of that, you can have attached jellyfish tentacles. Now, the problem with the attached jellyfish tentacles is the melanocytes, which happens to be the cells that cause the envenomation, can keep firing. Okay, they can keep firing even after they've been detached from the jellyfish themselves. They're quite transparent and they can be difficult to see. And the longer they stay on, the longer they're going to envenomate. Now, when jellyfish envenomation was first sort of coming into vogue, we used to use pressure immobilization technique for them, okay, because the venom was so profound. But because of the associated jellyfish tentacles, people were wrapping them up in the pressure immobilization. So, therefore, it was called, we don't do that anymore, and we remove the tentacles. Okay, that's basically what the main treatment is that we'll go into. The other type of jellyfish envenomation that can be dangerous is Irukandji syndrome. Now, most of the time when we're dealing with Irukandji syndrome is people don't know they've been stung when they're in the water. They come out of the water and they can be completely normal, like no symptoms whatsoever. But then within 20 to 30 minutes, they can develop Irukandji syndrome, which is characterized by generalized pain, the sense of impending doom. Okay, now you may laugh at that until you've seen someone with it. It is quite remarkable that is literally what they think. Okay, they think they are going to die, and they'll tell you that they think they're going to die. Okay, then they have nausea, vomiting, can progress to difficulty breathing, and associated sweating. Sweating can be difficult to find because obviously they've just come out of the water and it's generally at the beach on a hot day. Okay, but it's the severe generalized pain and sense of impending doom that are the big red flags associated with Irukandji syndrome that will lead to management. All right, but looking first at the management of box jellyfish, we obviously do CPR if we need to. If we need to do CPR, then unfortunately the CPR can go on for a long time. And it's best to try and get the antivenin brought to you with the emergency services. Okay, because evacuating them with active CPR is not obviously the best idea. So you really need to be able to give that antivenin on the site during CPR in order to basically bring this person back. Now, if they're alive, we need to focus on removing those tentacles. Now, seawater is safe to use for all tentacles to remove. And luckily for us, it's in abundance. Okay, so you can get buckets or containers of seawater, pour it over the person, and reports say that you can use your hand to remove the tentacle because the skin on your hand is thicker. I personally like to use a cloth or a rag in between in order to wipe it down, and I also like to wear gloves just to get those extra layers. Okay, but there are reports that says you can use your hand directly, so your call. Now, in the event that you have vinegar, you should use vinegar. Now, what the vinegar does is it actually inactivates those nematocytes. Okay, that's what it does. It doesn't do anything for the pain. Okay, so forget those people that tell you that it's a pain relief, because it's not. The person still needs pain relief on top of that. Now, once we get the tentacles off and it's vigorously clean the area, everywhere where there's a lash mark and surrounding, okay, really take a good look for these tentacles, remove them all, then we look at getting access. We need to get access. If you can't get IV access, we go IO, and we look at analgesia. Now, ice can help directly onto the tentacles, lashes, but they also can need opioids. Now, in severe cases of envenomation, like when they need antivenin, is when people are hypertensive, show signs of loss of consciousness, or have seizure activity. They will generally, obviously, need the antivenom. Now, if someone has large cases of envenomation, or realistically, if you have someone with a good amount of tentacle marks, then they should be evacuated. And they should be evacuated with continuous monitoring, and even after they're released, they can need to come back and be reassessed for 14 days because they can have associated rashes from the tentacles for 2 weeks. And if they receive the antivenom, then they can actually get antivenom serum sickness for 14 days. It basically feels like a really bad flu for 14 days. Okay, so these people are not going to be having fun after being treated for a box jellyfish. They'll probably never swim in the ocean again, realistically. Now, when we move to Irukandji syndrome, it's a little bit different. Sometimes it's quite benign, and you can treat it with analgesia, monitoring, and just gauge how bad they are. Okay, we often put a cannula in because these people can drop pretty quickly, and the ongoing management for some of the complications can mean IV access is needed. Now, Irukandji syndrome can come with associated hypoxia or respiratory problems, basically. So you can need to administer oxygen if the SpO2 is less than 93. And they also can get associated acute hypertensive crisis from Irukandji syndrome. And that's treated with GTN, so 400 microgram spray, every 5 minutes for 3 doses. And that's obviously on a consult. Okay, now these can escalate to needing a GTN infusion, just to let you know. Now, most of the people with Irukandji syndrome will end up in hospital, mostly due to the uncontrolled pain. So the pain from Irukandji syndrome is actually quite profound, which means most of them will end up going to hospital. Everyone with hypertension will obviously end up in hospital for ongoing management. But most of the Irukandji syndromes will go there anyway because it's extremely painful. Okay, we'll just finish up talking about things that we can do in order to prepare ourselves and prepare our party for potential envenomation. The biggest thing that separates us from a lot of other clinical parties is the ability to conduct health planning. So you really need to do that. You really need to know the task and the dependency that you're looking after, and you absolutely need to know the area and the associated risks of fauna and flora with envenomation and other irritations. Okay, so you absolutely need to do your research, and you need to prepare when you're going into those areas. PPE is amazing. Okay, most of these bites cannot penetrate layers of PPE, whether it's leather gloves, long pants, leather boots, whatever it is. A lot of these things can't penetrate. Even wetsuits in the ocean really stop most attacks from jellyfish stings. Okay, so PPE is very important. Water shoes is also a great idea for anything that you may stand on. Okay, so just encourage the use of personal protective equipment. Educate all your first aiders. Educate the CFAs in the region of anything that's quite unique that has specific management. Okay, pass the education on so they can help you with the management of these patients. You always leave creatures alone and encourage everyone else to leave creatures alone. As mentioned right at the start, most of these envenomations come from people who have startled an animal or have messed with an animal they shouldn't have been and subsequently have been bitten, stung. Okay, so that's always good advice. Despite all the good advice in the world, people still do mess with animals they shouldn't, okay, particularly around marine life. Remember that the Poison Information Centre is available for all poisons, including envenomation, so you can give them a call 24 hours a day for advice. Obviously, don't forget to call the MO for any associated pharmaceutical and evacuation priorities, but you can definitely call these centres for advice. Now, because there are a myriad of other creatures out there, more than we could possibly go through today, we're already looking around the 45-minute mark for this presentation. So I encourage you to have a look at the ADEL site, associated study guide and article, in order to get a more broader perspective of other creatures in our fine country and certain clinical considerations that we should take into account when dealing with anybody who's been subject to their envenomation. Okay, that brings us to the end of envenomation. There's really nothing more to say in this particular one. So until next time, take care.